welcome for this thyroid awareness or update today. And these updates are necessary for all the physicians and family doctors because after diabetes.
Thank you, Dr. Prasanna, for the introduction, Dr. Sangram Biradar for the invitation. And it's lovely to see Dr. Muruganathan. Thank you for your kind words. And Dr. Girish as well. A very, very warm welcome to all of you for today's thyroid update. Dr. Muruganathan was saying that Dr. Sangram is always ahead of everything. In fact, January, like you rightly said, is Thyroid Awareness Month. And from the Indian Thyroid Society, we are conducting a daily program. And Dr. Prasanna was the first one to kickstart this at the beginning of the month. And we will end it. Every day we are having a Facebook Live. In fact, it is running. And if Dr. Prasanna will permit me to leave after my talk, because I have to be present there as well. So I will continue with my talk now on thyroid disorder, approach to thyroid disorders in pregnancy. Please permit me to share my screen. Is it visible?
Yes, madam.
Okay, and I'm audible as well. So the topic is approach to thyroid disorders in pregnancy. Because hypothyroidism is the most common disorder, the major part of my talk will focus on hypothyroidism in pregnancy. Then I will touch upon hyperthyroidism, postpartum thyroiditis, and a little bit about goiter and thyroid nodules, which may also be seen during pregnancy. If we consider the effect of pregnancy on thyroid physiology, then all across, whether it is increase in the serum thyroxine binding globulin with the associated thyroid related consequences, you can see there is increase in total T4 and T3, increase in T4 production. The plasma volume increases with a subsequent increase in the pool size of T4 and T3, T4 production as well as cardiac output. Increase in the deiodinase expression in the placenta leads to increase in T4 production. And because of increase in the HCG in the first trimester, the free T4 goes up, the basal thyrotropin or TSH goes down, and the T4 production is increased. So I've just focused on the salient and important points which one needs to be aware of. What about the transport of thyroid hormones and antibodies across the placenta? So iodine is transferred avidly across the placenta. So maternal iodine needs to be adequate. If maternal iodine is not adequate, then the child will also have iodine deficiency with associated abnormalities. Antibodies are transported freely. This is important because when I'm talking about the antibodies subsequently, especially when we come to Graves' disease, this is of great significance. TRH is also transported avidly. TSH is poorly transferred, and thyroxine transfer is seen especially in the first trimester. TSH per se is poorly transferred. So if we see in this diagram, right through pregnancy, you will see that the free T4 goes up and it comes down later. The total T4 is always high, as is the TPG, and this is following the rise in HCG. Thyrotropin or TSH, there's a slight fall in the beginning and subsequently it is maintained. So if we see the individual changes, the free T4 trimester-wise will be normal throughout. Free T3 will be normal throughout. Total T4 will be high throughout, as will be the total T3. In the first trimester, TSH is normal or decreased. In the second and third trimesters, it is normal. Subclinical hypothyroidism vis-a-vis overt hypothyroidism. In overt hypothyroidism, the T3 and the T4 will be low and the TSH will be high. In subclinical, the T3, T4 will be normal. The TSH will be elevated. Usually it is less than 10. In pregnancy, HCG stimulates the thyroid, raising the free T4 and lowering the TSH, resulting in a downward shift of biological reference ranges for TSH in the first trimester. So if we have just isolated maternal hypothyroxanemia, that is free T4 concentration, which is in the lower 2.5 to the 5th percentile of a given population in conjunction with the normal maternal TSH concentration. So you might find a low free T4, especially in the first trimester. And the question which I will answer here itself, should we be treating isolated hypothyroxanemia with levothyroxine during pregnancy? The answer is no. It is not to be routinely treated in pregnancy. Okay, so if you just find a low free T4 in the first trimester, it is not to be treated. So most of my talk now will be based on the 2017, which are the latest or the last guidelines which came out from the American Thyroid Association. I'm happy to say that the Indian Thyroid Society first published its guidelines in 2012. They were revised in 2019. And now we have also updated them, and they are coming out in our journal, that is the Thyroid Research and Practice, Thyroid Disorders in Pregnancy, a consensus statement from the Indian Thyroid Society. So question is, in subclinical hypothyroidism, yes, overt hypothyroidism, we know there would be signs, some signs and symptoms, but what about subclinical? Yes, even in subclinical, I've listed some of the signs and symptoms which may be present. 30% of these patients may have some symptoms or signs of hypothyroidism. Regarding fertility and pregnancy, what is the prevalence of subclinical vis-a-vis overt hypothyroidism? Subclinical is found in about 2.3%, overt in 0.2%, and anti-TPO antibodies are present in about 11% of all pregnant women. And if there is history of infertility or miscarriage, yes, even more so. So I'll be coming to the significance of the antibodies a little later. Now, what are the TSH cutoff for definition from the various societies? The American Thyroid Association says it is trimester specific. The European Society, again, it is trimester specific. And note, the cutoff in the first trimester is 2.5 across board, European Thyroid Association as well. Second trimester is up to 3. And in some societies, it is 3.5, 3.05. But the majority of them, it is up to 3. So this is important to remember. In the first trimester, it is 2.5. You can see that was in 2011. But what happened in 2017? The recommendation was to use locally derived reference ranges from a specified pregnant population. However, if that is not available, then we use a locally derived reference range from a similar population from another country. So if the above is also not available, then the upper TSH reference limit is 4. So the first recommendation, which came out in 2017, is that the TSH reference range should be a population-based trimester-specific reference range. And the reference range determination should only include pregnant women with no known thyroid disease, optimal iodine intake, and who have a negative TPO antibody status. Now, the upper limit of TSH, the reference range Initial recommendation 2.5 in the first trimester, 3.0 in the second and third trimester. So there is most of the other recent studies, they have demonstrated just a modest reduction in the upper reference range. So 2011, we had much smaller population, which was studied, just about 5,500. But in 2017, the data is from 60,000 subjects. So there's a lot of difference between the data between 2011 and 2017. So what is the magnitude of the problem? If you look at even the 2 years from 2013 between 2015, overt hypothyroidism as well as subclinical, there's a significant increase from the data, the prevalence data, which we are seeing across the country. And if we are trying to choose the upper cutoff, this is from our study, 11 cities, 9 states across India. We were looking at the prevalence of hypothyroidism. If you use the TSH cutoff, look at the TSH cutoff at 4.5 vis-a-vis 2.5 or 3. You can see that there would be a tremendous increase in the numbers from 15% in the first to 44%, from 12.06 to 32%, and from about 14% to 34% in the third trimester. So this is the significance of the cutoffs that we are using. And I've tried to show you, because we do not have the reference range, so we are taking the ATA cutoffs as of now. What is the prevalence of, as far as the hypothyroidism is concerned? If we look at the antibody status from our data, in the first trimester, TPO antibody status was seen in about 18%, second trimester about 19%, and third trimester 22%. So about 18 to 23% of pregnant women from in our study had an elevated thyroid peroxidase antibody, that is TPO antibody. So this was a study from 541 women for determining the trimester-specific reference range. And the TSH here, this has been published by Dr. Marwa et al. It's mentioned in the guidelines of the ATA. And Dr. Marwa's data, as you can see, the first trimester is 2.1, second trimester 2.4, and third trimester 2.1. So the 2017 guidelines, what was the next important recommendation? I'm not covering all the recommendations, but the ones that are relevant here. Pregnant women with a TSH concentration of more than 2.5 should be evaluated for thyroid peroxidase antibody or TPO antibody status. Why are we talking so much about these TPO antibodies? There is a strong association between the association of overt and subclinical hypothyroidism with antibody status. So the prevalence of thyroid antibodies is 14.7%. Both TPO and thyroglobulin antibody 6.9, TPO antibody alone 5.7, and thyroglobulin antibody alone is about 3.1%. So with subclinical hypothyroidism, we must do in pregnancy, if the TSH is 2.5, then TPO antibodies must be assessed. What about treatment of patients with thyroxine in the presence of thyroid immunity? So again, this is data from 2006, Negro et al. 115 pregnant TPO antibody positive women who had a TSH of less than 3. They were randomized to levothyroxine treatment or placebo. The miscarriage rate was higher in women who had TPO antibody positivity. But once the patients were treated, then the miscarriage rate was much less. Similarly, for preterm delivery, these are the women who are antibody positive, and with treatment, you can see that there is significant improvement. So if you give levothyroxine, even in euthyroid TPO antibody positive women, the chances of miscarriage and preterm delivery are less. So this was the data of Negro et al. What is the other association? The adverse pregnancy outcomes between TPO antibody and thyroid dysfunction. So if you adverse pregnancy outcome, if you have raised antibody titers, it's about 85.7%, normal versus a normal delivery of 14.2%. Normal titers of anti-TPO antibody, adverse pregnancy outcome 36%, normal delivery is about 64%. So there is a significant difference if the antibodies are positive. What is the status of antibodies across the country? Anti-TPO antibodies are seen in about 21%, almost 22%. From Ahmedabad to Chennai, we have data. Ahmedabad, there was a data from 13.26% to Chennai, about 25%. Much more common in women, with a maximum prevalence in women between the ages of 46 to 54 years. So what is the next recommendation? What I showed you was Negro's data. So the recommendation here is women who are euthyroid, who have TPO antibody positivity, with a prior history of miscarriage, pregnancy loss, may be considered for levothyroxine, given its potential benefits in comparison to its minimal risk. So yes, we are justified to treat them, and 25 to 50 microgram would be a typical starting dose for levothyroxine. Euthyroid TPO or thyroglobulin antibody positive pregnant women should have the TSH measurement at the time of pregnancy confirmation and every 4 weeks through mid-pregnancy. So if there is history of recurrent fetal loss, miscarriage, we are justified to treat TPO positive euthyroid pregnant women. If the decision is not to treat, then they need to be followed up every 4 weeks throughout the pregnancy with a TSH. Now, in between, I will be discussing some cases as well. So she's a 21-year-old woman. Her menarche was at the age of 14. Her LH, FSH, prolactin are normal. Her cycles are irregular. In 2008, her TSH, her thyroid profile, she's euthyroid. In 2009, just the TSH was repeated. And you can see this is subclinical hypothyroidism. The TSH is elevated. At that time, a T3, T4 was not done. So she was started on 50 microgram. And the TSH is 3.6. I told you that for pregnancy, our target is less than 2.5. So the dose was stepped up to 75 microgram. And now you can see that her thyroid profile is normal. In this 2009, the TPO antibodies were done. And you can see that they are significantly elevated. So this is a classical case of subclinical hypothyroidism with TPO antibody positivity, and the patient was subsequently well controlled on a dose of 75 microgram. So the pregnancy outcomes. With maternal hypothyroidism, there is a 20% incidence of perinatal mortality and congenital malformations. Overt hypothyroidism, there's about 20 to even 40% chances. With subclinical, it is 1/3 as many. So it's much less, but yes, even with subclinical, we have similar morbidities associated. And it's just not one, there's a host of them, from anemia, congestive heart failure, miscarriage, postpartum hemorrhage, eclampsia, preeclampsia, gestational and postpartum hypertension, placental abruption, greater chances of lower section cesarean section, lower segment cesarean section, preterm delivery, anti and postpartum depression, lactation problems, low birth weight, myopathy, as well as a host of fetal and neonatal complications, from growth restriction to increased perinatal mortality, impaired intellectual and psychomotor development, developmental abnormalities, intrauterine death, congenital hypothyroidism, hyperbilirubinemia, and respiratory distress. So these are the reasons why we really focus on hypothyroidism in pregnancy. However, believe it or not, there are case reports of myxomatous women successfully carrying pregnancy to term. So what is the take-home message from this particular slide? That yes, we are aware of these problems, but a woman who comes to us, she's pregnant, she's now detected to be hypothyroid, we would not advise a medical termination of pregnancy. We would continue the pregnancy and we would start levothyroxine. That is extremely important. And this is the take-home message that I want to give here. So this is our data, which was published in the Sri Lankan Journal of Diabetes, Endocrinology and Metabolism. And we looked at the thyroid dysfunction in pregnancy. 162 pregnancies with fetal and perinatal outcomes in 138 cases. The overall prevalence of thyroid dysfunction was about 24%. Subclinical in about 18.9% was most common. There was history of abortion, significant, adverse fetal outcomes, significant, and a low birth weight was associated with thyroid dysfunction. So in our population, it was subclinical, which was seen in the majority of cases, overt in about 2.46%. Now coming to another case, a 23-year-old, she's married for 2 years. For the last 6 months, she's been having prolonged cycles. You can see that her TSH is grossly elevated. She is overt hypothyroidism. The T4 is significantly low. Her prolactin was also elevated. So just to highlight that because of the overlap mechanism, you can get a little bit of hyperprolactinemia associated with hyperthyroidism. In fact, it may be even more high, and you do not need to treat that. You do not treat that separately. The values will normalize once the patient is euthyroid. So this is typical hypothyroid phases pre and post treatment. Similarly, for another woman, you can see the typical hypothyroid or myxomatous phases. Another case for you. She's a 32-year-old who's been married for the last 6 years. Primary infertility. Her husband stays in Saudi Arabia and he returns every 2 years for 6 months. You can see that she's subclinical because her TSH is marginally elevated. Her T3 and T4 are normal. So what would we do here? The husband is not around for most of the time. He will be coming back for a specific time. Yes, the decision here would be to go in for TPO antibody status, which is important to decide whether the patient would subsequently be continued on thyroxine after she has conceived, after she has delivered. Here, we would start treatment and we would continue it till she has had a normal delivery. So irrespective of what is the status of a marital status, yes, we would start treatment, but the decision to continue the treatment for lifelong would depend on the antibody status. So what are the screening recommendations? Now, we'll go first of all to ATA 2017. ATA neither recommends nor rejects universal screening due to insufficient evidence. The exception is women who are planning and ART or already who are antibody positive. So there's a high risk approach. The decision point is not the TSH alone. The antibody status is the main determinant. If the TSH is between 2.5 to 10, total T4, they prefer over free T4, and high risk case finding for pre-pregnancy counseling. So different societies, again, some recommend no universal screening, some recommend universal screening, and the European also does not recommend universal screening. However, what we recommended in 2012 and which we continue to recommend from the Indian Thyroid Society is, yes, universal screening at the first antenatal visit. So with subclinical hypothyroidism, what would be the benefits of treatment? The symptomatic improvement, prevention of progression to overt hypothyroidism, reduction in the dyslipidemia, and subsequently lower risk of cardiovascular events, and prevention of poor developmental outcomes in children who are born to women with subclinical disease. So I've already discussed about the increased pregnancy loss, which is seen in women who are antibody positive, even with a TSH between 2.5 and 5 in the first trimester of pregnancy. You can see the difference between group A and group B. So the rate of spontaneous pregnancy loss in group A was 3.6, which was much lower than the rate of spontaneous pregnancy loss in group B. Group B are pregnant women with a TSH of between 2.5 and 5, and group A is a TSH with a less than 2.5. So there's an almost 2 times higher risk of miscarriage if a TSH is between 2.5 and 5 in the first trimester of pregnancy. Even with subclinical hypothyroidism, clinical thyroid dysfunction has been associated with the pregnancy complications, and there's 3 times more likely to have placental abruption. Preterm birth is also 2 times higher. And there is some reduction in the intelligence quotient of offspring of women with subclinical hypothyroidism, which may be related partly to the effects of prematurity as well. So what are the outcomes on the neonatal status? This is a systematic review and a meta-analysis. This was not an RCT. There was a trend of adverse outcome, but it was not very significant. So prospective results provide insufficient evidence to conclude that treatment of subclinical hypothyroidism is associated with improved neurocognitive outcomes. However, late onset of therapy in the late first trimester or second trimester may be a confounder. So this was the data from that meta-analysis. Now coming to an important case, she's a 28-year-old lady. She has primary hypothyroidism. She's 6 weeks pregnant. She's a known hypothyroid for 6 years on levothyroxine. 75 microgram has been her dose for the last 2 years. And you can see what is her TSH. Free T4, free T3, and TSH values. So you will agree that the TSH is definitely elevated. And what is the next step that you would like to take? The question here is, would you like to maintain the same dose, increase the dose, stop levothyroxine, or terminate pregnancy? So from what I have discussed so far, I'm sure and I hope you will agree that number 4 is not an option at all. So what would you like to do? You would definitely increase the dose of levothyroxine. In fact, when I come to subsequent slides, I will tell you that women who are planning to conceive, the dose can be stepped up even prior to pregnancy conception. Increase the dose of levothyroxine. So here the dose was increased to 100 microgram. That is a 30% increase. After 4 weeks, you can see her TSH is within the normal range for pregnancy, and the dose was continued at 100 microgram. And she was advised to monitor her TSH every 6 to 8 weeks. At 28 weeks, it is still normal. The ultrasound showed a normal fetus. She had a normal delivery, and the newborn was euthyroid. So this was a good outcome of the pregnancy. So what are the take home right now from the discussion that I have had? Preconception control in hypothyroid women is to be emphasized. Check the serum TSH level as soon as pregnancy is confirmed. You can increase the dose preemptively by 25 microgram or depending on the dose by about 20 to 50%. So you can preempt as soon as the cycle is missed. The dose can be preemptively increased by up to 50%. For previously diagnosed hypothyroid, we would monitor the TSH every 4 weeks during the first half of pregnancy and every 6 to 8 weeks thereafter. You would start off for overt hypothyroidism with a dose of 1.6 microgram per kilogram. If the TSH is less than 10, then the initial dose would be 50 to 100 microgram per day. Be careful because with pregnancy, we give iron and calcium. So we must separate that by at least 4 hours. So it would be a good idea to give the thyroid, of course, the thyroxine is given in the morning, first thing in the morning. So the calcium and iron can be taken with lunch or dinner. So if that will automatically separate it rather than specify that you have to wait so many hours. So if you just give that time interval, that is important. Women who have positive TPO antibodies and in whom we are not going to treat, we must monitor every 4 weeks. After delivery, usually we decrease the T4 dose to the pre-pregnancy dose and recheck at 6 weeks. And like I tried to tell you, for the women whose husband was in Saudi Arabia, if the original indication for T4 therapy is unclear, so the patient is subclinical, antibodies negative, we can sort that out here. We can stop the thyroxine for 6 weeks postpartum for re-evaluation. So this is again from the 88-2000 guidelines that we increase the dose of levothyroxine because of the greater demand during pregnancy. And the next recommendation, which I have again already told you, is that TSH should be evaluated pre-conception and the levothyroxine dose should be adjusted to have a TSH value between the lower reference limit and 2.5. So this is again a very important part of the recommendation. What is the screening threshold? I said from the Indian Thyroid Society, we are screening all the women, conception plan, the visit during the conception which is being planned, and the first antenatal visit. Other indications to screen by the other societies I have tried to list here. Age more than 30, past history of thyroid disease, family history, goiter, thyroid antibodies. If there are other symptoms or signs suggestive of hypofunction, even anemia. Anemia is a very important point. I'll be referring to a case subsequently. Type 1 diabetes, yes, there's a lot of, there's a very significantly higher prevalence of hypothyroidism because of the autoimmune nature. Any other autoimmune disorder, infertility, previous therapeutic head and neck irradiation, history of miscarriage or preterm delivery, and iodine deficient population. So see, you can, this is a woman, she has a goiter since the age of 14. Now she's married, she's antenatal, she is significantly hypothyroid, overtly hypothyroidism. And she was basically being just investigated for anemia. So anemia per se is an indication to check for hypothyroidism. if you have a strong suspicion. So the ATA guidelines, what do they recommend? If the patient is TPO antibody positive, the TSH level is more than the pregnancy specified range, we would treat. It was a strong recommendation. TPO positive between 2.5 and 4, we would consider. TPO negative more than 10, yes, we would treat. TPO negative, TSH more than the pregnancy specific reference range, we would consider. TPO antibody negative, TSH less than 4, then we are not going to treat. So the take-home points so far, the incidence of maternal complications in overt hypothyroidism are up to 40%, 1/3 in subclinical. 10% of pregnant women are TPO positive, and they are susceptible to subclinical hypothyroidism, postpartum thyroid dysfunction. Infertility and miscarriage are common with TPO positive women. Even mild or subclinical thyroxine deficiency in early pregnancy is detrimental to the mother and the fetus. When you have the patients who are already on levothyroxine at conception will require an increased dose during pregnancy. And I've already told you that you can preemptively, as soon as the first cycle is missed, increase the dose by up to 20 to 50%. Undertreated maternal hypothyroidism may have adverse impact on the child's neuropsychological performance. The TSH targets are important to remember. First trimester, between the lower limit of normal and 2.5. Second trimester and third trimester, less than 3. Universal screening is recommended by the Indian Thyroid Society. Now, moving on to hyperthyroidism, a little bit about postpartum thyroiditis and thyroid nodules. So Graves' disease is the most common cause of hyperthyroidism. It could be a toxic adenoma, solitary thyroid nodule, which is toxic, or toxic multinodular goiter. But gestation specific are gestational transient thyrotoxicosis and the transient hyperthyroidism, which is associated with hyperemesis gravidarum. These are the common ones, the others are rare. Now, there is a temporal relationship to hyperemesis. There is no evidence of pregestational hyperthyroidism. The findings are subtle because of a short duration. There will be no evidence of ophthalmopathy. It's predominantly T4 toxicosis, whereas in Graves, it is predominantly T3. Antibodies, whether it's thyroid receptor antibody or TPO antibody, will be negative, and it has a very short self-limiting course. Hyperthyroidism in pregnancy, again, there's a host of complications, whether it's maternal or fetal. This is typical Graves' disease. You can see a big gland with the eye signs as well. And you can see she's lost a tremendous amount of weight. So if you have a low TSH, this is the algorithm that we follow. As per gestation-specific criteria, we would reconfirm with a free T4 and a free T3. With a low TSH, normal free T4, free T3, it's subclinical. We will only follow up every 6 to 8 weeks. Low TSH with a raised free T3 and free T4. We would also look at the thyroid receptor antibodies, TPO antibodies, and decide whether it's Graves' disease, treat with anti-thyroid drugs, and if there is a history of, if there's a strong history of hyperemesis, then we would think of gestational thyrotoxicosis or the one associated with hyperemesis and then follow up. So the appropriate management, this supportive therapy for gestational and hyperemesis gravidarum, hydration, hospitalization if required. Anti-thyroid drugs are not recommended for gestational hyperthyroidism. If the woman is thyrotoxic, ideally, she should be rendered euthyroid before contemplating pregnancy. In the first trimester, propyl thiouracil is the preferred treatment. But because of the liver toxicity, the hepatotoxicity, after the first trimester, we switch to methimazole. We will monitor every 2 to 6 weeks. Thyroidectomy in pregnancy is rarely indicated. If at all, it is absolutely required. It is done in the second trimester. Serum TRAB, that is thyroid receptor antibodies, should ideally be done in the 20 to 24 weeks of gestation. And I told you antibodies avidly cross the placenta. So if they are present, it suggests that the child may have fetal thyrotoxicosis. So this is the significance of testing for the antibodies, especially in pregnancy. And then appropriate fetal surveillance would be required. Cordiosynthesis should be used extremely rare. Methimazole, the dose is 20 to 30 milligrams, is safe for lactating mothers and the infants. PTU up to 300 milligrams, a second line agent, which I told you only in the first trimester, and anti-thyroid agent should be administered following a feed and in divided doses. Excuse me, please. Beta blockers to be avoided in the first trimester, and they should be weaned as soon as the hypothyroidism is controlled because of the gross risk of growth restriction, hypoglycemia, respiratory depression, and bradycardia. Iodine is again contraindicated. Postpartum autoimmune thyroid syndrome. It can mimic postpartum depression, begins soon after delivery, and resolve spontaneously as well. It is an autoimmune disorder which presents 3 to 6 months after delivery. So with typical thyroiditis, we would get a phase of hyper, which is usually detected clinically, followed by a phase of hypothyroidism. And eventually at the end of 12 months, the whole cycle lasts about a year. After that, the patient usually becomes euthyroid. More frequent in diabetics, so hyper, hypo, euthyroid. Postpartum thyroid disease, there'll be a painless goiter with presence of TPO antibodies. Incidence is about 2 to 16%, with a 50% recurrence following a subsequent pregnancy. Mostly no treatment is required or the treatment is symptomatic. And if the decision to start levothyroxine, it can be discontinued after 6 to 12 months, and the patient is re-evaluated to determine the long-term requirement for T4. So if we are trying to differentiate between thyroiditis and Graves' disease, thyrotoxicosis is transient. In Graves' disease, it is persistent. TSH receptor antibodies would be negative, positive in Graves' disease. We would not, in pregnancy, we would not do a radioactive iodine uptake, and neither in the postpartum period because the mother is lactating. Symptom duration is less, no eye features, but in Graves' disease, in 30%, we would have features of thyroid eye disease. I would close with a couple of slides in relation to multinodular and simple goiter. More common in women, especially during pregnancy and puberty. Familial, the cause is usually unknown. Amongst the definable causes is iodine deficiency, goitrogen ingestion, or impaired thyroid hormone synthesis. Goiter, again, has been associated with pregnancy since antiquity. The volume of the thyroid gland per C increases by about 10% in iodine sufficient to about 30% if there's mild iodine deficiency. A palpable thyroid enlargement is abnormal in the pregnant women whose iodine is adequate. If the thyroid enlargement is detected and is accompanied by clinical manifestations of hypothyroidism or thyrotoxicosis, then appropriate evaluation, as I have alluded to earlier. If a discrete nodule is present, a fine needle aspiration cytology, and then subsequent management for the nodule. Fortunately, most thyroid nodules detected during pregnancy are not malignant. So this is a slide showing you a huge solitary thyroid nodule And again, some more solitary thyroid nodules. Thank you. Thank you very much. I'll be happy to take any questions.
Thank you, Dr. Sarita, because it is an excellent talk. It has been very exhaustive and complete.